a minute. I know some of you have messaged me privately to say you can't hear anything, and so this is just me testing out. You should be able to hear me. We have everybody else on mute as people are coming in. All right, so I think we'll go ahead and get started. I know that there might be some other people still trickling in, and that's the great thing about doing this online, is that hopefully people will come and be here when they're able to. I'm so excited to be here with all of you today and to talk about really my favorite topic to talk about and think about, which is trauma. And so just a few housekeeping things before I get started. Please feel free to put any questions that you have in the chat. You can send them to the group. You can send them to me privately. I won't be looking at them until the end, the last few minutes, but that'll be a good place to keep them so I can make sure to attend to any of the questions that you have. Also, I would invite you to use this time however is helpful for you. I've provided a pretty detailed handout in the hopes that that might free you up to feel like you don't need to take copious notes. And I'm always happy to share any other resources or anything that can be helpful to you in your work after the fact. And so my email address is listed at the end of the presentation. Please feel free to reach out to me and to make sure that I attend to any of the questions that are important to you. So I just wanted to take a minute to introduce myself and to talk a little bit about how it is that I've come to do this work about trauma and how I think about these presentations that I always feel very fortunate to do. My name is Allison Hrovat. I am a mental health counselor. I'm also an assistant professor of human services at Holyoke Community College. And in that role, I'm also the program coordinator for our Developmental Disabilities Direct Support Certificate Program. And so in that role, I teach classes, I reach out and help students who are wanting to come back to school to get education to supplement the work that they're doing in the field. And for me, my career as a mental health counselor has really been about trauma. I started learning about trauma early on in my training, and I was working in a family violence center. And at that time, in the early 2000s, when we were thinking about people experiencing trauma, we were thinking about it as these sort of, distinct categories. So you might take a course on helping people through family violence. You might take a course on grief and loss. You might take a course on combat trauma, but we weren't really looking as much at the whole umbrella of trauma. And as I'm sure will be a surprise to none of you, we really weren't at that time thinking about how trauma impacts the lives of folks with intellectual and developmental disabilities. That has been a field that has been really slow to move, but it has definitely happened. And so in my early work as a mental health counselor, as I was starting to get training on trauma, I started working with more and more families who were thinking about ways to support their loved ones through the experience of trauma. A lot of times, trauma services were set up to focus on the people most immediately affected. So in the family violence centers, you know, the person experiencing violence, the children witnessing violence. But then we started seeing how trauma and how those experiences of trauma affect entire systems. As I moved forward in my career and I started getting to know more and more community groups, at this time in my life, I was living in Cleveland, Ohio, which is where I'm from. I started partnering with organizations such as the Department of Developmental Services, who were saying to me, these services that are offered seem like they're open to everyone, except to people with intellectual and developmental disabilities. Like, we don't see a bridge. What can you tell us about how these experiences of grief and loss and trauma impact individuals with developmental disabilities? And I said that I was willing to partner with them and to try and figure it out and to try and learn. And so that's how I started sort of building this bridge in doing clinical work in the mental health field with individuals with developmental disabilities and their families. So what I'm hoping to talk about today and Thursday is the most important parts to me about trauma. Obviously, I teach a course on trauma that lasts 16 weeks, and in those 16 weeks, I feel like we barely cover the topic. So I'm not intending to give you everything there is to know, but I really feel like the basics of trauma are pretty easy to grasp onto. And the more I learn about trauma, ironically, the more hopeful and optimistic I become, because the experience of trauma is universal. Most people experience trauma in their life. And if we can have a sense of how it impacts us, not just emotionally, but in the functioning of our brain, how it impacts the individuals and families we work with, how it affects our kids, our neighbors, I really believe that there's so much hope for transformation. And so I'm excited to be here today to talk to you about some of that information and to hopefully give you things that feel like you can take them in and use them immediately. So today we're going to really focus on defining trauma, looking at the impact of trauma and how it works in our brains. We're going to talk about how trauma leaves a residue in our bodies, in our minds, and how that impacts us, especially as we're trying to adapt and learn new things. And then on Thursday, we're going to pick right up and start with talking about what we know specifically about how trauma impacts folks with intellectual and developmental disabilities. And then we're also going to tackle a little bit about trauma and COVID-19, because I think that we can't really address this topic without thinking about the extra layer that's upon all of us right now. Okay, hang on, I have 10 different things to click here. Oh boy, there we go, okay. So the first thing I want to just say is to recognize that right now, without knowing the circumstances of any of your lives and just, you know, reading the introductions in the chat, it is obvious that we're all living in a time of incredible stress. Between managing the stress of the global pandemic, especially as people who are working out in the field, people who are trying to support others in managing it, that experience of stress and the experience of living in this trauma, oh, sorry, that was not for me. I got a private message, is something that wears on all of us. And so what I want to say is that nothing that I'm presenting today and Thursday is intended to be more stressful or to trigger or to evoke any kinds of painful emotional experiences. And yet, anytime we talk about trauma, there is that chance. And so I want to invite all of you to take care of yourself as you need to. This session is being recorded. The PowerPoint slides are readily available. Take time for yourself as you need to. Make sure that you take care of yourself. Because if there's anything that I hope people walk away from this presentation with, it's an appreciation for what it means to take care of ourselves and others in the moment of trauma. And so to that end, I want to invite everyone to take just a moment. One of the things that we're going to be talking about on Thursday when we talk about adapting a trauma-informed mindset is taking regular opportunities to tap into whatever senses are available to us as individuals. So whether that's a sense of touch, taste, smell, sight, sound, taking a moment to just connect with one of your senses and to think of one thing that you see right now, that you smell right now, that you hear right now, that you taste right now. And so I'm going to ask you to take a moment to respond in the chat with one thing that you're taking in from one of your senses right now. Just one simple thing. That's great. I'm incredibly envious of all of you that are feeling air conditioning right now, because I most certainly am not. So the idea of something as simple as this is to start to teach our brain to come back against one of the biggest impacts of trauma, which is a difficulty or a challenge to be in the present moment. Trauma has a way of taking over our brain and steering it towards the past and towards the future, to thinking about things that have happened in the past and worrying about those things and trying to make sense of those things, or trying to anticipate things that are going to happen in the future. And so the more that we can offer ourselves and nudge ourselves into moments when we're really in the present moment, the more we can counteract that one really powerful impact of trauma. And we're going to talk more about that as we understand the mechanisms of trauma in the brain. When I present in person, I always bring people Play-Doh, and I give that out for this exercise because Play-Doh is a great tool for mindfulness. It has a scent, it has a touch. The more you keep it in your hands, the more it warms up. Some of you might remember that it has a taste if you sampled it when you were a child. And so having these tools that help us connect to our senses, you'll see as we talk about the mechanisms of trauma in the brain, is a really, really effective tool that shouldn't be cast aside as something we use on a regular basis. So a few of you mentioned in your sensory check-in something about your pets. And so when I teach about trauma, I start with a case study of one, which is my cat Dewey. I'm not going to give you his whole history, but if you want to learn more about Dewey, you can enroll in my trauma class at HCC because we tend to talk a lot about him. But suffice it to say that if you've ever known a pet, you have known a being that has experienced some sort of trauma. A lot of times pets are separated from their mothers at a young age. Our cat Dewey was rescued from some pretty horrific experiences, and so he came to us with this experience of trauma wired in his brain. And all of these behaviors that didn't look so great wired into his brain as ways that he would cope with his trauma. Now, the reason I start out by talking about Dewey is not just because he's adorable, but that is part of it. If we can look at a cat like Dewey and we can understand that when he acts aggressively and injures another cat, it is a communicative action and a way of him trying to resiliently cope with his trauma. If we can allow that for Dewey, perhaps we can allow that for human beings when we talk about the ways that people try to resiliently cope with trauma in ways that might not look nice. But the other reason that I start out by talking about Dewey is that, interestingly, when we look at the brain and we look at the way that the brain responds to trauma, the way that my human brain responds to trauma is the same way that Dewey's very non-human brain responds to trauma. And so if we can understand the tools that are available to us in the moment of trauma through the lens of our Dewey brain, it can give us some empathy around the options that are limited to us in responding to trauma. And so I want you to keep Dewey in your mind as our first case study as we start talking about what trauma looks like. So in defining trauma, it's important to know that trauma is really defined more by the impact that it has on a person than by a list of items that we check off. When we look at the history of trauma, what we see is that initially trauma, like so many things in psychology and human services, trauma was initially understood through the lens of the military and through the lens of combat trauma. And so at that time, when we were looking at trauma as the experience of someone who had gone through combat, there was kind of a checklist of things. If you've experienced this, or this thing, perhaps you've experienced trauma. But what we learned as time moved forward is that really psychological trauma is up to a unique individual experience. And it's really up to the subjective experience of each individual. What happens in the moment of trauma is that a person experiences something. This could be a one-time event, or this could be an accumulation of chronic experiences that overwhelm their ability to cope and to integrate that experience into the way that they understand themselves and the way that they understand the world. So when we look at that definition as something that's subjective, what we know is that I can't tell you whether what you experienced is traumatic based on simply knowing what happened. What I have to listen for is how that experience impacted you as an individual. Something that I think about often when I'm trying to make sure that I'm having my brain centered in this subjective understanding is, years ago I was in a minor car crash with my family. My sister and her husband were in the front seat. Myself and my younger sister were in the back seat of a four-door car, a very small four-door car. And we got hit from behind by a student driver who I could see coming up behind us at approximately 2.1 miles per hour. I could see him coming and that he was coming too close. And so I had that moment to anticipate the accident. In the front seat, my sister and her husband were completely stunned by it. He tapped our bumper at, 2.1 miles an hour. And the two of them went into hysterics, like, oh my gosh, is everybody okay? We need to call 911, we need to call the ambulance, can you move? And my sister and I in the back seat are just thinking, this is nothing, we can wipe off the damage with a handkerchief, like this is no problem. Still to this day, my sister will sometimes reference the accident as something that was, for her, traumatic, because her experience was so different than mine, just 6 feet away from her. And so bearing in mind that we are really listening for a subjective experience, we can't really give a list of the kinds of things that we know create psychological trauma, but we can give some ideas. So it can refer to one-time incidents, natural disasters, medical events, surgeries, deaths, sudden loss, a sudden loss of a caregiver, violent events, assaults. It also includes responses to chronic and repetitive experience, such as abuse and neglect, community violence, chronic experiences of oppression and marginalization, enduring deprivation. The thing that's really significant about these definitions, as we start thinking about some of the community traumas that we're experiencing now related to COVID-19, also related to racial trauma, is that those are things that kind of bridge both of those categories. These are both chronic, ongoing things that we're managing, and then there are these flashpoints of emergency. And in some ways, as we start talking about the brain and how the brain manages trauma, it's the combination of those two things that really keeps people revved up, that it's both this baseline of enduring this trauma and then these flashpoints of increased attention to the trauma. And so one of the things that's really important for us to think about is that in terms of the mechanism of the brain does not distinguish between a traumatic event and what we might call a trauma trigger, something that reminds people of the trauma. The brain only knows to detect danger or safety. So even those things that trigger or remind us of a traumatic event are experienced by our brains and our bodies as a traumatic stress. And so we also have to think about the fact that it's not up to my opinion to say whether something is or should be triggering to you, right? Your brain is doing its own work to process that. When we look at the different types of trauma, there's some categories that can help us make sense of it. And I think this is especially important when we think about the families and individuals that you're working with, that there can be single episode trauma, so an event that happens that's traumatic. There can also be those ongoing repetitive experiences. And then there's this third category, which is a type of chronic trauma, but is specifically significant, and it's what's called a developmental trauma. And a developmental trauma is a trauma that happens during a developmentally critical period, which for most people is the entirety of childhood, but especially early childhood. That those kinds of traumatic experiences that happen in those developmentally critical moments impact a person in a very specific way, impact the development of their brain in a very specific way. We'll get to look in a little bit at some images of what that looks like. But oftentimes developmental trauma presents in what might feel like a more hardwired way. That's not to say that, that people can't heal from that kind of trauma in very significant and meaningful ways. The one thing that's really encouraging about understanding how trauma affects the brain and being able to look at images of brains that have experienced trauma is that we can also look at images of brains that have gone through a process of healing and recovery. And what we can see is that the way that the brain is activated by trauma can be rewired in a more healthy survival-oriented way. And so we have evidence to show us that. Then the last category of trauma is really complex trauma. And complex trauma is really not so much of what happened or how many times, but it's that the accumulation of different traumatic experiences in life have come to a place where they really impact every system of a person's being, cognitively, behaviorally, emotionally, that most of their responses and reactions are built surrounding trauma. And complex trauma isn't intended to say that it's worse, that those cases are somehow less hopeful or less optimistic, but just to say that when we're looking at someone who has this complex experience of trauma, we really want to make sure we think of trauma as being at the center of anything that they're coping with in their life, that trauma is always in the room for that person. Another thing that's really important to think about as we talk about trauma, and specifically as we think about healing and recovery from trauma, is the role of attachment. And this to me is, I've had the opportunity to present to audiences like this several times in my life. The first time was about 8 or so years ago. And it's been amazing to me how much information has come out in that time that's relevant to the connection between trauma and intellectual and developmental disabilities. But this is also the point where I feel so honored by the work that you do, because when we look at what can help people recover from trauma, all roads lead back to a relationship. All roads lead back to the safety of a relationship with another person who can see and who can comprehend the impacts of trauma in a compassionate way. Because the truth is that a lot of times trauma is rooted in a lack of attachment or a disruption of attachment. When we look at early childhood traumas, oftentimes they accompany a disruption in that most important relationship, that first relationship with a primary care person. Doesn't have to be a mom, doesn't have to be a biological parent, but a steady,
hi honey.
Sorry, I just had to mute one person. A steady relationship with another person. Having one.
Hi, this is Carrie. I'm sorry to interrupt, but can everybody mute themselves? There was some, you could hear some background noise there. Okay,
Great.
thank you.
Thank you. So when we think about having that one healthy attachment in life, that is protective in so many ways against the impacts of trauma. That doesn't mean that it, prevents people from experiencing trauma, but having that sense of attachment is very protective in terms of the impact of trauma. Conversely, when there's disrupted attachment early on in life, if a child is moved from placement to placement, if a child is moved from setting to setting, if a child has significant medical needs and needs to be hospitalized for a period of time, there can be some disruption in that attachment. Again, I want to say it's not that that can't be rebuilt, but all of those things in and of themselves in that critical developmental time can constitute one kind of trauma that can be significant, especially when we see the impacts later on in life. And so where you come in is that, you know, the lack of attachment can be part of a traumatic experience. And the path to healing from trauma, the path to recovery, is rooted firmly in the ability to have supportive relationships with other people who are steady and who are, you know, to one degree or another, predictable and reliable, and who have a sense of understanding what it means to experience trauma. Oh. All right. So we're going to shift into talking about the impacts of trauma. And after we talk about the impacts of trauma, we're going to take a peek inside the brain to take a look at how these impacts are rooted in our brain. And that'll be kind of where we end up for the day. So the impacts of trauma are extensive. The potential impacts of trauma on our brains, on our bodies, on our relationships, on our ways of functioning, on our bodily systems are really wide-ranging. I think the way that trauma has gotten so much attention is because people have started to realize that it's really, in addition to everything else, it's also a health crisis. Because we know that trauma is connected to all kinds of health outcomes, all kinds of behavioral outcomes that are damaging. Years ago in the late 90s, there was a landmark study between the CDC and Kaiser Permanente, where they followed about 17,000 patients and took a look at how many ACEs they'd experienced, how many adverse childhood experiences they'd experienced, and then made a correlation between those adverse childhood experiences and negative health outcomes. And what they found is that the connection, the more ACEs a person may have had, the more long-term negative health outcomes they are likely to experience. And what was really meaningful about this study is it was really the first time that anybody had thought that trauma lives anywhere other than in a person's brain and in their emotions. They'd thought to look at how this is experienced in the entire bodily system. And so, in addition to looking at the impacts on the body, they started looking at what are the other experiences that intersect with trauma. And so we know that all of these sort of exacerbating factors in and of themselves constitute a trauma, but also can accompany the life of someone who's trying to cope with a traumatic experience and can intensify the experience of trauma. We look at chronic poverty, homelessness, having an unstable or unsafe living environment, experiencing community violence and oppression. Depending on, again, the developmental stage, where a person is in their development, that has the potential to really exacerbate the experience of trauma. All other health concerns, all other mental health concerns, addiction, substance abuse, a lot of times in my work as a mental health counselor, people will really want to try and sort of tease out, like, which came first, the chicken or the egg for me? You know, how did this sort of cluster of experiences happen? And what people often find is that the experience of having gone through a trauma obviously makes a person more likely to experience some of these other health outcomes. But then the opposite is true, that if you're already experiencing difficult health concerns, if you're already experiencing mental health concerns, and then something traumatic happens, it impacts your way of being able to respond. And so those things really go hand in hand. The symptoms of trauma are pretty wide ranging. Whenever I work with an individual or a family and they come to me and they've experienced something traumatic and they say, all these things are happening, is that normal? I always say yes. I always say yes, because the truth is that however we're responding to trauma is our body's way and our mind's way of trying to respond to something very abnormal and very unexpected. And so there really, to me, is no normal or no right answer. Some of the common things we see is shock, denial, disbelief, a sense of disorientation, confusion, anger, irritability, anxiety, nightmares, a sense of guilt, shame, withdrawing from others, feeling hopeless, feeling disconnected. Those are all some of the more common things that people experience. And then when we look at how these things are experienced in the body, we really look at a few different things. The first is hypervigilance. So a sense that that we're always on guard. We're always looking for what's going to happen next. This also goes along with hyperarousal, where our body is at a permanent state of readiness. Our heart rate is up, our stress hormones are raging, and so we're ready to go at any time. Hyperarousal is what we tend to see most in people who've experienced trauma, but for people who've experienced significant trauma, we also see the opposite end of the spectrum, which is people who really are hypo-aroused. They really don't get excited by anything because that mechanism in their body has been sort of burnt out. And the last that we look at is dissociation. And dissociation is a really healthy experience in small doses. So our brain helps us dissociate or takes us out of the moment to give us a break from what's happening. Dissociation happens all the time. Maybe sometimes when you're driving home from work, you get in the car, and before you know it, you're home and you don't remember anything about the experience. Your brain has gone into another place. Perhaps you're dissociating right now. It happens all the time. But when it becomes problematic for a trauma survivor is when it happens frequently and without any ability to kind of tune back in, to kind of move out of that dissociative moment. So all of these things are things that we can expect our bodies and minds to go through in response to trauma. Okay, so now we're going to talk a little bit about how our brains handle trauma. And this will be sort of the last big chunk of information that we tackle today. I've got my eye on the clock to make sure that we allow some time for your questions. So when we think back to Dewey, our case study, this is where Dewey's brain really comes into play. If we think of the human brain as a house with additions, this can help us understand how our trauma responses happen in sort of the least sophisticated parts of our brain. So we're going to start with the bottom of this list, which is the reptilian part of the brain. The reptilian part of our brain is the brain stem, the part of our brain that we share with reptiles. And this part of our brain is responsible for the most basic survival mechanisms. So breathing, breathing, choking, breathing, sweating, going to the bathroom, drinking. This part of the brain is responsible for detecting things. So this part of the brain can detect when there's a change in temperature, when it gets really cold. This part of the brain can detect when there's too much wetness. Interestingly, this part of the brain cannot really respond to those things. So the perfect example of this is a few months ago, there was a news story about how this weather station in Florida had started predicting falling lizards as part of their weather report, that people in this community should be prepared for like rain of lizards coming out of the tree. And the reason for this is because the temperature was vacillating wildly. It was getting very, very cold at night. And lizards can detect that there's a change in temperature, but they don't have the part of the brain that can do fight, flight, or freezing, right? All they can do is shut down their entire system and sort of go catatonic, and then they fall out of the tree. So to get to the part of the brain that is responsible for fight, flight, or freeze, we have to go to the Dewey part of the brain, which is this intermediate part of the brain. This is the part of the brain where emotions and learning take place. So this part of the brain can have a choice between fight, flight, or freezing in the moment of stress or danger. This part of the brain is responsible for some level of emotional capacity, to have an emotional connection, to feel things. Those of you who have a mammalian pet at home, I'm sure know that that's possible for a mammal, to have those emotional experiences. This part of the brain is capable of learning. So pets can learn things, pets can learn how to anticipate things. This part of the brain does not have any sense of time. This is really important when we start talking about trauma. This part of the brain has no sense of sequencing, no sense of context, so it can't put things into context. It can't say, oh, I've been in this situation before, and I know what's going to happen. Those of you who have pets at home, and you come home and you've been at work for 6 hours, and you walk in the door and your pet acts like they haven't eaten for 76 days, it very much feels that way, because they don't have a sense of time and tracking in the same way that the human part of the brain does. This part of the brain also isn't capable of modulating responses to be socially appropriate, right? Like, this part of the brain isn't really capable of saying, well, I know I feel stressed out, but I probably shouldn't, pee on my owner's shoes, right? This part of the brain doesn't have the capability to think of lots of possibilities. This part of the brain doesn't have the capability to imagine and to problem solve long into the future. But this part of the brain, this dewy part of the brain, has something very, very important, which is the amygdala. And the amygdala is the brain's smoke detector. The amygdala is the part of our brain that detects when something feels unsafe and feels dangerous. And it detects that based on our experience. So just like most muscles in our body, our brain is a use-dependent muscle, which means if we flex it in certain places, it gets stronger. If we don't use it at all, it gets weaker. And so this smoke detector tunes in to our experiences of the world and says, these things are dangerous and these things are not dangerous. Our brain is an amazing organ, because it also seems to have information downloaded into it from generations before us. So, something that's always interesting to me about my cats is that they seem kind of unfazed if, like, a mouse gets in the house. But if I get a new pair of shoes that they've never seen before, it makes them puff up and get scared, right? Because their smoke detector has somehow evolved so that they know how to handle the threat of a mouse. They don't know how to handle the threat of new shoes. And so when we think about our smoke detector, it works sort of in the same way as, like, the predictive text on our phones. So you know how sometimes you start using a word a lot that isn't a common word, and it corrects it over and over again. And then you use it a lot and it recognizes that that's a word that is common in your life, and it corrects it the right way. Our smoke detector works in much that way. So then the last part of the brain, this blue part of the brain, which I think of as sort of the sparkly human part of the brain, this is where all of the other advanced functions happen. So this is where advanced language happens. This is where timing and sequencing, learning, being able to take on more advanced intellectual tasks, being able to come up with an appropriate way of responding things, being able to consider the consequences of our actions, advanced empathy, being able to execute a plan, having an imagination, being able to imagine new possibilities. All of that happens in this sparkly human part of the brain. And so when we think about what happens in trauma, the first thing that happens is that the smoke detector goes off, and the smoke detector says, danger, danger. In that split second, our brain makes all kinds of decisions. It prioritizes survival above all else. So that sparkly human part of the brain goes offline, unavailable to us. We can't really use or rely on any of the human functions in the moment of a traumatic, stressful experience. What also happens is that the right brain and the left brain pretty much disconnect. They're not communicating with one another. So we see more right brain activity, intuition, spatial, tactile, all of our sensory messages on the right side of the brain. The left side we don't hear a lot from. That's the logical, analytical, sequential part of the brain. That's also where our advanced language is. So sometimes if you've experienced something traumatic and you have a hard time putting it into words, a hard time telling the story of what happened, that's because your brain made the incredible decision to help you survive that traumatic experience. And the cost of doing that is not being able to access some of those functions of the brain. So then fight, flight, freeze instincts take over. Our brain makes the right decision so that we can survive the threat. In this moment, we also have our cortisol going way up. So our stress hormone is raging. It's telling our body, danger, danger, stress, stress, get busy. It's also shutting down the serotonin in our brain. So that chemical that makes us feel calm and relaxed is getting shut down. And you can imagine what happens if we're stressed out over and over and over again. Stress hormone up, serotonin down. Stress hormone up, serotonin down. It gets harder and harder for our brain to tap into that feeling of to that chemical of serotonin. Our immune system is also shut down. If you've ever been stressed out and then got sick at the most inconvenient time, it's because your brain is working right as it was intended to. It shuts down our immune system. We're not able to do complex brain tasks, and it also impacts our motor coordination. And so what happens is that as we go through more and more and more experiences of stress and traumatic stress, this pattern is reinforced over and over and over again. What happens then is that this pattern becomes the shortcut of our brain. You know, that distance between danger, danger and emergency response becomes shorter and shorter, so that it happens so quickly that it makes it hard for us to sort of build in the moment to say, no, hang on, this feels dangerous, but am I actually in danger? So what we see is that the brain responds in this way in order for us to be able to survive. Our brain is so good at survival, and it ends up feeling so inconvenient for us, the trade-offs that it makes to help us survive a threat. When our brain highlights all the senses, it turns on that information so that we can get more and more sensory data. Why? Because it can use that sensory data to better predict a danger the next time. I did a training a few weeks ago, and the title of the training was something like, "How have I never realized how loud my housemates chew?" And it was talking about the stress of living with the coronavirus, but it was talking about how when our senses are heightened, we're taking in way more refined sensory information, and chances are our housemates are driving us nuts because we can hear, we can sense, we can detect things more acutely when our brains are activated in that way. And so our brain starts to make these associations between something that felt dangerous and that turned out to be dangerous. This association ability is so important. It's how we learn anything. It's how our brains help us function. But it's also really inconvenient when we have an experience that tells us cars are dangerous, and then we have to get in a car the next day to drive to work. It creates this problematic loop for us to try and figure our way out of. So I want to, just before we take some questions, I want to just show you a few images. This is obviously a pretty extreme case, but it really is good at illustrating what happens when parts of a brain are overused and parts of a brain are under-accessed. So the scan on the right is the image of a young child who had lived in orphanages in Eastern Europe and had gone through significant periods of deprivation. And what you see is that front part of the brain, where in the healthy brain, it's lit up bright red. Bright red means that part of the brain is regularly being accessed. If we understand what I just communicated about what happens in trauma, what we know is that in order for us to regularly access the human part of our brain, we have to not be chronically under traumatic stress. Because when we're under traumatic stress, that front part of the brain is shut down. So what you see in the brain on the right is that the back part of the brain, that smoke detector, is bright red. And that is the reddest part of the brain. That brain is detecting danger, 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 danger at all moments. And it's shutting down that front part of the brain, which over time leads to that front part of the brain being underdeveloped. We also see the middle point part in the temporal lobes. That's part of the brain is formed largely in connection with other people. So that's when we form communication and language, whether that's verbal communication or other kinds of communication. And when somebody's neglected, as in the instance of this this person, they don't have an opportunity to develop that part of the brain. What we also see is that when we're looking at early childhood neglect, it also impacts the size of the brain significantly. And the thing that's really the reason why there's so much access to these kinds of images is that the reality is that for people who experience significant trauma later in life, rarely do we have like a before scan of the brain and then like an after. But in these young children, we're able to take comparative looks to see what the impact of this kind of neglect and trauma is on an early brain. And so what happens over time is that the neurons that fire together wire together. So if all we know is danger and survival, our brain becomes programmed for danger and survival. Danger and survival helps us to survive. Like that mode of operating is super important for us to be able to survive. But it comes at the cost of us being able to learn new things. It comes at the cost of us being able to take in new information. It comes at the cost of changes to our nervous system, changes to the way our body functions, our GI functions, our immune functions. A lot of times there's a high correlation between people who have experienced trauma and chronic stress and autoimmune concerns because of that function in the body, because the brain has to make that trade-off. And so, as I said earlier, the most significant challenge for trauma survivors is the ability to be in the present moment and to make decisions based on the present moment, not based on the things that have happened before, the things that are being interpreted as a threat. Because remember that when we're in that survival brain, there's no supervision of the part of our brain that can factor in context, that can factor in the safety of a relationship with another person, that can factor in things that we've learned and ways that we've grown since the last time. Okay, so I'm going to pause here so that I can respond to any questions from today. Woo, hang on.
Thank you. So this is Carrie. I'm wondering if you could stop sharing your screen because I cannot see the chat box. So I want to help you out with the questions if I can. Thank you.
Yes, I can do that. Okay. Let's see. So handouts. Carrie, where can people access the handout that I had provided?
So after this webinar today, I am going to be sending everybody a PDF of your PowerPoint today.
Okay.
So anybody who registered will have access.
Great. Let's see. And yeah, and also at the end of that presentation is my email address, which actually I can type also into the chat here so everybody will have it. Okay, so we have a great question here. Why aren't PET scans regularly done for individuals with intellectual and developmental disabilities who may have experienced unknown medical trauma, and also for foster adoptive children? Wouldn't it provide great insight and thus allow providers, parents to be able to provide this trauma-informed support? So this is a great question, and you've tapped into what is definitely a big controversy. I mean, I think that at the root of this is a few different things. One, I think like anything, we want to use PET scans as one data point. And so what people have argued is that if everybody gets brain scans, will reduce people's capabilities down to a chart, and that will, as all of you know, miss so much of the refined differences between individuals. The other part of it is truly financial. I think that a lot of times it's interesting when I teach my trauma class, there's all these different case studies, and a lot of times what brings on a case study that we have access to is some kind of other tragedy or some sort of court case, something that kind of pushes the envelope towards us using that kind of diagnostic tool. So I think that finances have a lot to do with it. I think that there are a number of researchers out there who do feel like greater access to this information, especially for those kids who are young and who can still really benefit from early intervention and different kinds of activities in their young age. So there are researchers using this tool and who are advocating for it to be more widespread, but it hasn't quite happened. In fact, there are two researchers that we talk about in my trauma class, and we kind of talk about the pros and cons because they've sort of sold a model of marketing the ability to do these brain scans to inform treatment. And they sell this product to families who have the money to take advantage of it. Some families who have used it will say this changed our life. Other people will say it's like selling snake oil to vulnerable people because it still doesn't provide us the full picture of what's happening. So I think it's just like tangled up in a debate. And I think that the one thing that has been helpful, as I said, the first time I did a training specifically for folks like you who work with intellectual and developmental disability, there was hardly anything out in the world. And I was really talking just from my experience of kind of making it up as I go and what I understood. In those 8 years, there's been a lot more movement. And I think that just the shared understanding that people with intellectual and developmental disabilities experience trauma and have very healthy, resilient responses to trauma that can be worked with, just that realization in the past few years has opened some doors to being able to incorporate this information. So I have two more questions. With early intervention services, trauma services, could the brain of the child who has experienced severe neglect grow and heal? So what we for sure know is that it absolutely can and does transform the brain. One of my favorite book recommendations, and it changes everyone's life. So if you take nothing else away from this, but The Boy Who Was Raised as a Dog is a book by Bruce Perry that gives all kinds of examples of children who, some of the kids come to him and, have already passed those developmental stages of gaining language, of gaining different kinds of, self-care behaviors, being able to feed and eat and those things. And some of those kids that he works with have been neglected their entire life. And then he starts working with them and he focuses on the way that the brain develops. So when we look at early intervention services, the thing that's amazing about that work is that it focuses on the order of how the brain develops, or what is called a neurosequential approach. So we think about what the brain needs at 1 month of age, and then we think about what the brain needs at 4 years of age. Those are two really different things. And so if we recognize that the lack of attachment happened at 0 months, and we start thinking about what a brain needs at 0 months to develop, and we use those interventions that way, it absolutely shows incredible growth and incredible development. So if you have a nonverbal individual, is there a way to identify if they may have experienced an individual trauma that may not be readily flagged, similar to the car crash you explained? So we'll talk about this more on Thursday, because I think this really is such an important and critical question. But just to give you like a short answer, I think that the way that we can identify that we can identify trauma. I'm not suggesting, and it is not my approach, to ask people relentless questions about the traumatic things that have happened in their life. In fact, to me, that's actually not that significant. It's not important to me to have the details of what happened. But I think that if we make a case for how trauma impacts people, how trauma impacts people's functioning, and we look through a trauma-informed lens, which we'll break down on Thursday, so I promise you'll know all about what that means. We're looking for changes in a baseline. We're looking for adjustments in the way somebody copes. If we're talking about a trauma that may have happened way in the past, that we don't have a way of getting that record, I think sometimes it's helpful just to assume that there is a trauma history there and to provide trauma-informed supports. Because much like universal design for learning and all kinds of accessibility initiatives, trauma-informed supports help everybody. Trauma-informed supports help me to be a better teacher, to be more successful in the classroom, to be more successful as a counselor, but they also help people who might just need an experience of feeling safe in an environment. So I think there are some things that we can do to recognize those things, and we can make some assumptions, not because we're trying to label what somebody's experienced, but because if we make that assumption, it opens the door to all different kinds of supports that we can provide, that we probably should provide anyway. I mean, that's my whole goal, is to have a trauma-informed world. And I think that if we can build that, it gives all people different ways of engaging and responding. Yep, nonverbal individuals give signs, aggressive behaviors, shutting down. What are the differences in traumatic events that occur before the child has language? Let's see. Yeah, Dr. Amen is exactly who I was talking about, that he has definitely generated a lot of buzz and a lot of debate. So it's a topic that I always love to discuss in class. So why don't we hold the question on traumatic events and language, and we'll start there on Thursday. And in the meantime, if you have any other questions that you want me to make sure to attend to, please email them to me. I'm always happy to adjust my plan because none of this is meaningful to me unless it's meaningful to you. So thank you so much, and I look forward to seeing you on Thursday, and I look forward to hearing your questions in the meantime. Thanks for doing what you're doing. Do something nice for yourself today.
Well, thank you, Allison. That was terrific. And we'll see all of you on Thursday.
Great.
Thank you.
Thank you.
Thank you.
So I think, Allison, you need to close out your presentation.
Okay, so close out that. Do you want me to log off at this point?
Yeah, that would be helpful, and then I can kind of take over. Yeah, and I wanted to apologize. I introduced you, but I was muted.
Oh.
And I didn't realize I was muted.
I
So sorry about that.
A private chat, but then I was sort of losing track of everything, so I just dove in. But thank you.
Yeah, and then also you couldn't advance the slides.
So the problem was that I had clicked off of the PowerPoint presentation. I feel
okay.
So now I figured that out for the next time.
Oh, okay, good. All right. Okay.
It was operator error, totally.
Oh, okay, good. All right.
So
I was
I'll
just
see you Thursday.
so I could advance them, so I was just trying to be able to get you what slide you needed to be on. But anyways, you're a really good presenter. Appreciate it.
Thank you so much. One question I got a few times is if there's a different link for Thursday.
No.
Okay.
Same link.
Okay, let me.
No. Here, let me, I could just chat. I see the chat now. I can, same link. Alrighty.
Okay, great. Thanks so much, Carrie.
Okay, all right. So I'm gonna leave, and I'll see you again on Thursday. And
Sounds
hope, and I'll this time I'll make sure I'm unmuted.
good. That's okay.
Anyway, all right.
Thanks, take care.
All right. Have a good one.
You too.
Thanks again.